Okay, great. So we are live here. So Tim Talk Live, episode 3, Melanie McArdle. I am your, hold on, I get some banners too I like to play with. So Loudmouth and Chief, Tim DeBona here. We will try to answer questions as they come in. I will switch over to that. I'm going to do a little scrolling bar here too. Nope, that was terrible. That's going to have your information on it just so people know how to reach you. And hopefully I remember to do that later on. But if we get any questions in, I will do my best. There were some at the end of last episode I didn't see. So I will do my best to make sure I pay attention to this. So Melanie, what I've been advertising to people is basically that this is what you do is something that everyone that I've talked to about this, if they don't work in my company, have never heard of it before.
Yep.
So can you just tell us what neuropsych testing is and what, because, yeah, let's just start right there.
Sure.
What is neuropsych testing?
So neuropsych testing means that we're looking at like a lot of cognitive and behavioral psychological issues that might be coming up for patients across a lifespan. A lot of the concerns that we get for testing are ADHD, autism, learning disabilities, even behavioral like dysregulation, particularly in younger kids. And then as people age and get older, there's a lot of questions about dementia, if there's any type of mild decline, what functioning might look like after a stroke, or, say somebody has a brain tumor removed, even cancer treatment. It really kind of ranges any type of like psychiatric and neurological disorder.
How does it come in with cancer?
So cancer treatment sometimes can cause, particularly chemo, or depending on radiation where it is, can cause what's kind of referred to as almost like residual effects.
Yeah.
So you can notice that somebody starts to have a little bit more decline once they finish chemo treatment.
Yeah.
Everybody's a little bit different, whether or not that was there prior and it kind of just brought it to the surface. Everybody kind of is an individual case by case.
Right. That's interesting. Yeah. So, well, I mean, you've met my fiance. She's had, I don't know if she opened up to you about that she had brain cancer.
Yes.
At all. Yeah. So after that, she used to be a great historian, had awesome memory. Apparently, I never knew her back then. And now she has memory issues. In the beginning, I think she was having issues remembering people's names immediately after surgery. And although that's not the case anymore, there's times where she's, and I've always had terrible memory. So I like that she's on my level. But like, so even for people like her, so she's, I think, 40, she can also potentially benefit from this to understand maybe like where specifically the memory issues are, right?
Yeah, exactly. And understand a bit more of how to optimize on her strengths. So whatever cognitive strength she has, again, everybody looks a little bit different, but it's helpful to know that because the goal is to say, here's what we're dealing with that you're really good at. Let's try and maximize that, right? And then the weaknesses we can target with whether it's day-to-day strategies, therapy, medications, whatever it might be.
What about like traumatic brain injuries, or even people having like CTE and things like that? Do you get involved with those cases sometimes?
Yes. So traumatic brain injury, certainly. It depends a lot on, timeline of like when it happened, how severe it was, whether or not testing would happen, kind of right away. A lot of times that's not the case. We like to wait just a little bit. But it all depends on if it's like sports related. They'll do some, cognitive testing, like impact testing is a big thing.
Okay.
And then if you're seeing effects, say, once you're out of what would be like a mild to moderate cognition issue of, I've had a brain injury that wasn't putting me in a coma. That was really serious, but I felt dizzy for a couple of weeks. I had headaches. I had to stay out of school. Then you'd want to evaluate once they're out of that phase of kind of feeling dizzy with
because
headaches,
you don't,
right?
Not that you don't care. You don't treat more episodic issues. You treat chronic issues, right? Things that are ongoing.
Well, we want to know if there are any residual issues. So if we're hitting you right at the point of, I just got a concussion, you could look very different in testing at that point versus 6 months down the road, a year down the road.
Yeah, gotcha. Okay, interesting. So I know that the process takes a lot of hours. You do like an interview. So when I had this for my oldest daughter, and I've had it twice for her, there's interviewing for the parents. So there's like a form. So I filled out a form. Their mother filled out a form. They filled out a form. I think we even had a teacher or two fill out the form, maybe even the psychotherapist filling out a form. I'm not sure if that was the case or not. But there's a lot of information that comes that way. And then there was like a direct interview that I think was long, like 2 or 3 hours, something like that.
Yep.
And that's just the starting point. And then I know on your side, there's like a dozen, 20 hours that go into this whole deal, right? So why does it take so long? Like, what are you actually doing for this assessment?
Yeah, that's a great question. So again, it varies. Some people could be a little bit longer of a case than others. But it's the interview process and writing up everything that we've gotten from the interview, as well as teachers, like you said, both parents, therapists, psychiatrists, neurologists, even like primary care. We get referrals from a lot of different specialties. And the idea is to implement any information that we have from them into the report.
Okay.
And the report is almost supposed to be, yes, it's a medical document, but you also want it to be more of like a narrative of the patient, right? Because everybody looks different. And the idea is to individualize the treatment plan for this particular patient.
Yeah.
For kids, that means that we're looking across several different settings. We want to look at school and home, right?
Mm-hmm.
Same thing for adults, just home and work.
Right. Yeah. Because my daughter's life at their mother's house is very different than their life at my house.
Right. Which
Yeah.
is why it takes so long. There's so much interviewing. So my interviews I do 2 separate. I'll do one that's virtual with the parents, and if it's a child, the child, and then they'll come in and I'll do a second so that I can make sure that I have all the information I need before moving forward for the testing. And the testing is what takes the most time. That's at least a couple hours for every patient.
So inevitably, though, you're going to have contradicting information, or you probably always have contradicting information in these, right?
Yeah, particularly if you're giving the same forms. So say, like, you probably got maybe the same form that her mother got,
Yeah.
right? And the idea is to see from each angle kind of what might be going on so that we, again, can target it in treatment, whether it's therapy, medication, school interventions, whatever it might be.
Okay.
So sometimes they look a little bit different because people's perspective is different.
Right, right.
But that's okay, and that's expected.
And it's probably also useful. Like, so for instance, let's say, I mean, I can't even imagine how diverse, even just on children, the results are that you get. I mean, obviously age by age, it's going to be dramatically different, you know, because my daughter was first tested at 8, so prepubescent, and then at 15.
Mm-hmm.
So, and I might get into that a little bit later because it was unbelievably helpful, especially the most recent one that we went through. Both of them were extremely helpful and in very different ways. But like, what if you have a patient that is being intentionally deceptive? Let's say they're, you know, because I'm sure, I don't know what goes through people's heads.
Mm-hmm.
Maybe they don't want to do this testing. Maybe they are trying to game the system and trying to answer things right instead of answer things accurately. Like, do you, through your evaluation process, are you looking for trends that can reveal deception or lies during the test too? Is there ways to do that?
Yeah, there's ways for us to identify when, you know, what a patient is experiencing maybe is really kind of out of even a clinical norm.
Okay.
So we do have ways to kind of be able to do that and work with the patient to figure out why that might be.
Yeah.
Sometimes people who come in with like a lot of emotional turmoil at the time of the evaluation, some of their questionnaires that they answer can look like that.
Okay.
So it's taken into account kind of what is more of like a transient versus like a chronic type of issue. And again, that's important to know. Those are data points, right? Because now we know what we need to target in treatment for them. And it might be different than what they initially came in with.
Right.
So it's important to get all of that information so that we can get a comprehensive picture of the patient themselves and say, here are the things that we need to work on to make things easier for you.
Okay. Yeah. Because I can imagine too, even if they are trying to maybe say that they're less intelligent than they really are, but then there's so many questions on that they might answer like a very difficult question very well and some simple questions really poorly. And through that, you might kind of see that it's not really truthful, or maybe the parents are showing one even unified message, whereas the child seems to come up different. So do you ever have to bring in your patient for a second round of interviewing if there is some difficulty on your side being able to kind of like see, you know, what actually is happening?
Yeah, certainly. That would usually happen if, say, I scored up all of the testing came back with something that was really not overly clear. There could be a little bit of a follow-up. Sometimes it's also possible to do a follow-up after somebody gets the evaluation with the results.
Yeah.
Because especially with parents, a lot of times they're going to have questions, right? When they're reading the report, they might not understand what something means,
Yeah.
even though you've already gone over. It's a lot of information to talk about in an hour appointment for the feedback session with them. And then you're sending them a 20-page report for them to try to process. So sometimes you can meet with the parents a second time and the child, if the child's interested, obviously, too.
And I love that report, because the report, it's unbelievably long and sometimes difficult to understand, because it's deep. It's a deep clinical report, but and that's why I named this one the roadmap to your child's brain, because that's how I felt like it was. Like the first time, I sat down with the Psy.D at the end of it and was like, I heard what she had to say. My daughter had read more books at 4 years old than I have read in my entire life, which albeit is not really that necessarily impressive, because I don't really read much. But there was this unbelievable push for, like, whenever it came down to reading, I mean, she was popping them out so fast and just had this massive thirst for it. And then all of a sudden we started noticing other items that were very frustrating. Like if it was like, hey, go tie your shoes, they would go tie their shoes. If it was, hey, you have 5 seconds to tie your shoes, flatline, like too much pressure. And it's like, well, this isn't really a pressure situation. So we started noticing certain things like that. So, when I was talking to the Psy.D, by the end of it, I was like, okay, so basically I'm trying to put you got to dumb it down so I can understand, because I think that's got to be tough for you too, because you have extensive education, you have a doctorate in this, whereas none of your patients, very rarely are you going to have a patient that's going to have, or a parent that's going to have that level of education. So I was like, the way I'm figuring it is we have like this Ferrari type of like engine, but it's stuffed inside of like a Kia. Like it's moving so fast. Like the vocab IQ was through the roof. Like there was a 1 or 2 standard deviations from one IQ score to the other, and then another 2 to the next one below that. So it's like, when it comes to taking this and putting it on paper, like writing it or speaking it, and I'm just thinking, like, that's got to be so unbelievably frustrating to be like, but it helped me immensely to understand where she was at 8 years old, and it helped me get what was going on. So I think that's going to be, is that difficult for you when it comes time to have the conversation with parents, to put it in a way that is useful to them? And I mean, they must ask you, like, what do I do with this information now?
Yeah, and again, every kid's a little bit different, but most parents, when they're coming in, the goal really is to help their kid.
Yeah.
That's the whole reason that they're coming in, is what can we do to make things easier so that they're not struggling and that they're thriving, right? A lot of times parents, when they get the feedback, most of the time they'll be like, this makes complete sense. Usually you're not going to have something, hopefully, that feels like it's too far left field, that's really not in the realm of what they were considering, because a lot of times when they come in, they've already spoken to some other provider, right?
Yeah.
Whether it's a pediatrician, a psychiatrist, a neurologist, and they might have already said, like, this could be what's going on. So it's almost as if we have an idea coming in of what we could potentially be dealing with, that the parents will know that that's what we're looking for.
Got it.
And then you just don't want to be so targeted that that's the only thing you look for, in case something else is also going on. You don't want to miss it. But yeah, it's a lot of information, but usually the parents, whether you're giving them the information of what strengths and weaknesses are, and what needs to be done, they'll usually be pretty receptive to it, because it's the end goal is in the best interest of the kid. Right. So who doesn't want that?
Well, and I think the thing is too, is that it's so much more tangible and definitive coming from you, whereas, I mean, I think mental health as a whole is an unbelievably difficult field. I personally think it's very much in its infancy. I don't think we know really a lick of what's going on. I think people like yourself, we're, mental health, trying to do our best with everything, but I feel like it is just this frontier that we have just touched on, and there's so much that we don't know. Like even, I don't know, like, I mean, you're seeing like the understanding of autism just exploding right now, where I knew nothing about it. And that was actually what kind of put things together for me with my daughters, when they turned 15, I felt like I was grasping at straws. It's like, okay, there was one point where there was terrible depression, but that has thankfully gotten so much better. There's anxiety. There's this shutdown after school.
Mhm.
And I'm like, why are you so lazy? Get up, come on, do your things, do your homework and stuff like that. Then when we finally got that diagnosis, and like a couple of weeks ago, we had the McLean program,
Mhm.
and we picked up a diagnosis of OCD, and I'm like, we have ADHD, we have and it's like so confounding. And then through the second round of testing, we got the autism diagnosis, and I'm like, I mean, I've heard of it, but I don't really know it. So I delve in like we do with our kids, of course, don't we? And I'm like, I'm going to learn. And then I learned about masking and autism burnout. And it's like, oh my God, they're putting on this fake face. And I don't mean to get so siloed into one diagnosis, but it all of a sudden, instead of feeling like I was on the defensive, trying to like compensate here, compensate there, now it's tangible. Now I can read books on this stuff, understand it more. Like now, and I might be I'm a little bit eccentric, I guess, but like I feel like I can even I feel like I'm seeing through the matrix. Like when you buy a new car and all of a sudden you see your car all over the place. Yep. I'm seeing friends groups, and I see the one in the back of the group with like having issues with eye contact. And I'm like, there it is right there. That's the one in the group with the autism or something like that. And I'm like, and I connect with folks with autism now on yep. like I'm almost gravitated toward it. And my daughter now thinks that I have it, and because I guess it's very much genetic too. But I'm refusing to get tested because God knows what I have going on up there. I know it's a lot, and I don't think anybody wants to know.
That's a whole nother podcast.
That's
right?
a whole, yeah. But I think at the end of the day, it's like, now I feel like I can be on the offensive. Now I feel like I have these tools to get, and it gives you confidence. It's like, people aren't afraid of the dark. They're afraid of what might be in the dark.
Yeah.
It's, we humans generally have a fear of what they don't know. And the more you know, the better then you can get some control over things. And that's, I think, what's amazing about what you and your colleagues do, is that you're able to bring something that doesn't come from counseling, and it doesn't come from psychiatry. Mm-hmm. It comes only here. And I don't know why there is this relatively like a new service? I mean, why is it that it's so unknown in the mainstream?
Yeah, I mean, neuropsychology has definitely grown, and it's expected to continue growing, but it's not necessarily new. It's just our understanding and our access to the services and what testing can actually detect has grown a lot over the last several decades.
Yeah.
And the more that we learn about things like autism, ADHD, even dementia, like I think the services are in higher demand because we're able to say definitively, like, yeah, this is what's going on. And we have these individual symptoms, because your daughter's going to look different than the next kid, right? And the next kid's going to look different than that kid. It's the same thing across the lifespan. For every patient that comes in, everybody looks slightly different in testing. And that's important because that determines how we're going to individualize their treatment. Right. And how we're going to individualize school recommendations.
Yes, which is a great segue. So now you have your results, you deliver it to the parents. Let's say, for instance, we'll stay with children for now. We'll get to the other stuff in a minute. But now they're going to say, okay, great. So now I can understand what's going on. What do I do with it now? So now obviously you provide diagnosis, you can diagnose, right? And this can now go towards a potential like IEP, 504 plan.
Yep.
You can now, do you advocate for them? Or is it just your report speaks for itself, and they can take that to the school and say, I would like to have the following, what is it called? Accommodations. How did I forget that word? Accommodations for my child. My child doesn't like bright lights. My child gets freaked out with loud noises, whatever it is that's going on. Mm-hmm. And then try to figure out what would be the best tools to allow that child to succeed with wherever they're going to school.
Right. Yeah. So the report is going to have all of the recommendations in there for the school to be able to review.
Yeah.
Sometimes it does happen where we will get pulled, the neuropsychologist will be pulled into the IEP meeting just to discuss it a little bit further.
Yeah.
But the idea is in the report to lay out all the recommendations in detail as best you can.
Okay.
And then if there is any type of follow-up needed, then yes, we would attend an IEP or a 504 meeting with the school and with the parents.
So I'm trying to think of that. So what if there's a situation where, because I think there's some, and I don't know this stuff, maybe you do, I'm not sure if you do, but like in public school, I think if there's a situation where you're maybe, I don't know if you would do this, but recommend them to not be part of a public school and be part of a more specialized school, like a school that's focused on autism or whatever else. Because there are a lot of those, which I didn't know about either, which is
Yep.
awesome that these things, and it seems like a lot of them are popping up. There's lots of different, options that are out there. Even gyms, I've noticed, there's autism gyms. There's like one of my colleagues, he's got this client that's doing this up on the North Shore, north of Boston, and it's really interesting how focused we're getting on helping different people out with different issues. But and I think the schools are required to fill out something, or they might even be able to provide tuition reimbursement, even total or something like that, or partial or something like that. But they might pull you in to ask you questions for something like that. Like the school might want to be 100% sure, because I'm sure it's a blow to the school's budget, or I don't even know how that stuff works. But are those situations where you might get called in?
Yeah, so situations where, say, there might be some discrepancy between what the school is giving for resources and what they have versus what the parents are asking, having somebody objective to come in and say, like, here's what's reasonable. Because sometimes, like, parents might have an idea of what works for their kid, but it might not be available in the school. So trying to find a middle ground of to what does work, right, without overloading the school system as well, because it's the same here. We only have as many resources as we possibly have access to.
Yeah.
So being able to kind of find a compromise sometimes.
Okay. Sounds like fun. I mean, I would just picture that you probably went to school to do all this work, and then those conversations must be very difficult at times.
Yeah, certainly. The idea is just to have the child, the student, with your best interest in mind for them.
Of course, yeah. But it's like in pediatrics, we always say the worst part of pediatrics is dealing with the parents. Like it's always, you love the kids, you love dealing with that, but it's dealing with the other side of it that's always difficult. So let's talk about the geriatric side of it now too, because I'm sure there are folks that are watching this that have become caretakers. Oh, I can probably stop scrolling that thing like crazy. That's probably annoying people. Let me actually go to comments. I'm sure we don't have any yet, but I just want to keep that in there. Where is it? God, I'm so terrible. I should be good at this by now. Okay, I think I have it up now. And yeah, if anybody has comments, please shoot them in. I will ask the questions that you guys throw in there. And I guess for people who are caretakers, so I had a close friend who was caretaking for both of his parents, and I would tell him, like, you have no credentials to be able, like, they both had significant, like they're both homebound, had significant mental health issues. And, people get put in very difficult situations. It sidelined his career. He correctly chose his parents over work and stuff. Very admirable, very, a very giving man. However, my thoughts are without, if mental health issues, especially for the elderly, are very complex and difficult to diagnose. It's a completely different game than kids, right?
Yes.
So to get into that aspect of it, and we were talking about this beforehand, how I've only dealt with internal med clinicians in the past, and they've told me that it takes usually a couple of years just to confirm a dementia diagnosis. So what is your role? Because I imagine there's several folks it's not just you to come up with this diagnosis. It's going to be you in tandem with other specialists as well, I would imagine, for folks that are seniors that are going through potentially Alzheimer's or whatever it is that they have.
Yeah, no, that's a great question. I think the best way would to be walking through what that process might look like for people, so that they can kind of understand when it should be something that they look into, right? For whether it's their husband, their wife, their mother or father. Usually what will happen is somebody will go into, say, a primary care physician, right? And they'll get some type of screener. It's a very brief screener just to see if something's going on. Particularly if, say, their reporting is not as great. They say they're forgetting their meds. There's a loved one with them saying, like, oh, we have some concerns about driving, their memory, word finding difficulties, right? They'll do a quick screener. If the screener comes back okay, that's great. They'll still probably send them for testing if there's concerns, though.
Okay.
If the screener comes back a little bit lower than we would expect, they automatically should be sent for neuropsych testing.
Okay.
So a lot of that does come from like a primary care physician, or if somebody's already seeing a neurologist and
Yeah.
say they got some imaging, right? They got an MRI that shows that there's maybe some abnormalities in the brain imaging, whether it's, we're seeing lesions and there's concern of if they've had any type of like MS, if there's strokes.
Oh, interesting.
If we're concerned that there's a little bit of atrophy, whether you're just seeing a little bit of the brain volume shrinking,
Yeah.
but we can't confirm whether or not that is translating into a dementia or an emerging dementia.
Right.
They will come for neuropsych. We will do all the cognitive testing. We'll talk about their functional abilities, do baseline testing to see where we would expect them to be prior to these issues.
Okay.
To be able to confirm cognitive decline and whether it's meeting that threshold of dementia.
Oh, okay. Okay. So I was thinking at first you're going down like you're basically just used to rule out stuff, but you can also confirm cognitive decline. So that's very useful.
Yep.
So some of these folks aren't going to be great historians.
Right.
I mean, do you do the same method where you survey loved ones, people like caretakers or whoever it is that's close to them, their clinicians, and same type of process?
Yep.
And then their difficulties with providing information is just fuel for your report. That just goes right into it. Okay, so they can't answer questions. They don't know who the president is of the United States. This is like I'm using some of the, like the mini mental state exams and stuff like that.
Good job, Tim.
Yeah, I get it.
You know what you're doing.
Basically can treat patients now. Let's go. So it's a simple, but it's, I mean, God, and they're going to have so many chronic health issues too.
Yep.
So, I mean, is that even more challenging? God, which one's more challenging between children and
well, I think that depends on the case by case basis.
Okay, yeah, that's fair. Yeah.
The medical complexities that do come with older people, because automatically we just know that there's going to be more medical issues as we age for most people.
Yeah.
It's certainly something that we have to kind of tease apart and be able to take into account, like what's the magnitude of some of these medical issues on their cognitive decline, because your physical and cognitive health are one and the same, essentially, right? As soon as your physical health starts to go and say you're feeling like you have uncontrolled diabetes, your hypertension's not controlled, you're going to notice that your cognition day to day is also not as great.
Okay.
So being able to have records from, like I said, primary care, to be able to confirm anything that the patient has said as far as their medical history and medications with loved ones or medical records is also important, to be able to see where they are as far as understanding what's even going on with them and how they're managing medications that they need to be taking for their own health.
Okay. In the beginning, we talked about people having, let's say, like a physical traumatic injury to the head. You had mentioned cancer. And I'm sure there's plenty of other diagnoses that could lead to adults. And by adults, I'm talking about like anywhere from like mid-20s to, let's say, mid-40s or something like that. So these folks, I would imagine, generally also would not necessarily consider themselves candidates for neuropsych testing. How is it, if there was, because I think it's easier when there's a caretaker. I'm the parent of these children. I know that something's off. I think they should be tested. I'm the child of my parents. I know what they were like historically, and I know where they're at now. There's something that we don't know about, the doctors aren't catching.
Yep.
Then great. They're a great candidate, right? So how do I know, let's say, and I imagine significant other would be one, but let's say I don't have a significant other, but maybe I have concerns and maybe I don't. I mean, how do I self-assess to see if I'm potential? Maybe I went through something recently traumatic, mentally or physically. I mean, because I imagine it can even happen, I'm skiing and I just take a couple of headers and that could potentially lead, because I mean, your brain is just like soaking in that skull and just bouncing off the sides. I imagine there could be potential issues that pop up. I mean, like in football, they say you could get like these mini concussions every single time, like those folks at the line of scrimmage, like when they're slamming into each other every down, there could be mini concussions almost every single down with the way that they slam into each other. So is there, how if somebody was watching, they may be concerned about themselves. What would be a way, if there's a way, to self-assess or at least ask a couple questions that might lead them to knowing that it should be a consideration?
Yeah, so for younger adults that are coming in, so say they're in college, they're working, there's no concern for dementia. We don't need to worry about, school interventions,
Mm,
right? A lot of those people come in because they're either in therapy or talk to a primary care where they're noticing, say, that they're not able to pay attention at work or they feel
yeah.
like they're falling behind. They have a lot of low motivation, lack of energy,
Yeah.
and they're concerned, is this maybe something like a depression or is it more ADHD that has not been diagnosed, right? Because the
Okay.
more we learn about ADHD and autism, the more these things are coming up,
Okay.
right? To see whether or not.
Don't take this personally.
We'll debrief after, Tim. You'll be
No,
fine.
I don't want to know. I don't want to know.
But it's helpful for them because the concern for them is like, well, it's impacting my job. It's impacting my relationship, right?
Yeah.
My significant other says that they say something to me and I'm not paying attention.
Right.
Those are usually ways that they'll identify to kind of come in themselves, or if they're with a therapist who's like, this might be something that's going on. I think we should get neuropsych testing.
Okay.
And in that case, yes, what you're talking about with collateral information, it's always best to be able to get somebody who can speak to the patient currently and as a child.
Okay.
So we'll usually try to at minimum speak to like a significant other or like a sibling if we can't get, say, parents.
Right.
involved.
Because I mean, medical professionals are great. They can provide some color and some great history maybe, but they don't know the day-to-day life with that person. So it's
right.
Okay. So you've started this practice, not even a year in, right?
Just a little over a year.
A little over a year. Okay. Well, congratulations.
Thank you.
How simple was this to create this practice?
Simple.
It's a joke, right?
Yeah.
You have time to spend.
So much time, yeah.
Yeah, I'm sure you're taking vacations all the time.
Right.
So what is it like running your own practice? Because, I mean, you started off just you, right?
Yeah. Yep.
Because I don't remember the name of the title. What's her title?
Oh, she's a psychometrist. She helps with the testing and scoring.
I've never heard of that. Is that just what a psychometrist does, or are there other duties for psychometrists, like typically?
Yeah, those are the main things. It depends on who your psychometrist is. So,
okay. I had never heard of that job title in my life until today.
Yep.
So, but you started off alone.
Yep.
Okay. So what was that like going through that? Because you've gone through some amazing institutions, I mean, really the best institutions to learn under. So when it came, what made you get to that decision that you wanted to run your own practice? Was it due to, constraints of being an employee and wanting to do things your own way? Is it more of just, this is what I always wanted? I mean, it's tough because, clinicians typically, the vast majority of you guys aren't made to be business people, but often end up being put in a position like that to run your own practice. And it's very difficult for clinicians to do that. So how did you come to the decision that you wanted to run your own practice?
So it wasn't an easy one, certainly. I had just really kind of finished postdoc and gotten my feet like firmly on the ground as far as me being an independently licensed clinician. Because that looks very different when you're training under people, right? And then having to kind of go out on your own.
Right.
I had worked in hospitals for, over a decade. And really
what kind of hospitals?
A lot of them. So either psychiatric hospitals, medical hospitals. I worked, my internship was in New York City up at a major medical center.
Okay.
And then McLean was my postdoc. So really kind of running the gamut of like just medical based with like a psych component versus just standalone psych facilities.
So you've done this work with all ages?
Yes. Yep.
Awesome.
And then I've had some training in private practice, and I had actually left the hospital mostly because the drive into Boston was a bit too much for me.
Yeah.
But I went into private practice because I liked the pace of it where I'm allowed to slow things down and really be a bit more attentive to the patient.
Gotcha. Yeah.
That's one of the things that kind of drove me into private practice to work for somebody else. And then as I started to get further and further along, I thought, well, one day I think I want to open up my own practice so that I can kind of, like you said, do things the way that I want to within reason, obviously, and be able to manage my own patient policies, practice policies that I feel are the best for the patient and my employees.
I mean, that's the best thing about being self-employed is that you can set your own schedule. You can manage things the way that you want to. But you definitely don't have to answer anything about your private life. But I imagine this has turned your life upside down because the amount of work, the hours that you're putting in here, it's when you're running your own shop, it's especially by yourself, immense.
Yeah.
Like, very demanding.
a lot of weekends and very late nights, early mornings.
Yeah.
I'm still trying to find that balance. I mean, I don't know that you ever really fully do.
Yeah.
So things are busy now, which is great. We're, getting patients the access to the care that they need, which is the
Good.
most important thing. But yeah, it never really shuts off.
Oh man. Yeah. And how do you look at so you've had this running for about a year. Where do you see yourself going with this? Do you want to keep it as like a solo shop? Do you want to expand it? What are your thoughts with that?
That's a great question. I would have to say I'm not totally sure right now.
Yeah.
I like having the individual aspect of it because again, I can kind of run things a bit more the way that I want to. But as far as a group practice, like getting people the access to this and the demand is out there.
Yeah.
So a group practice, I think, is certainly something that can be on the radar.
Right.
Once I feel that I'm kind of firmly on the ground and have figured out, that's the first year. So I just wanted to see how
you
it
want
went.
predictability, you want
Right.
dependability.
Right.
And that's what any business would want. And sometimes that's very difficult to get. I had this one client that we just parted ways recently, but she and I are very close and we talk all the time. And she she always used to say, Tim, like, is this what it's like? I've been in practice now 15 years, and every single year there's been at least some point or for several months that I was worried about going out of business. And I was like, that's, I think, how it is for everybody. I think everyone that's running their own shop, and it's probably a healthy thing to always be worried about that. But where you are right now in something that's in high demand, how far out are you booked right now, approximately?
We're booking into July right now.
Into July right now. So that's 3 months.
Yep.
What is typical for folks of your discipline?
Yeah, that depends. So pediatric, particularly if you're going to go to like a larger institution, those can be anywhere from like a year to 2 years. Private practice kind of varies depending on what the patient population looks like and location. Some can be 3 months, 2 months. Some can be 6 months to a year.
Right.
It really does kind of vary depending on the type of cases that they see.
And that's important too, yeah, because if you have, obviously if you have the cash, you can improve the frequency of when you can get seen. But if you want this to go through health insurance, what's the best method? So if somebody's watching this and they're saying, this is the testing I want, but there's no way in hell I'm going to be able to afford someone of your credentials that is working for 20 hours. So what is the best step for them to go to try to determine if they're going to get covered?
Yeah, so I always encourage people to call their insurance carrier and just ask if neuropsych and psych testing is covered, just so that they can kind of get a baseline as to, yes, our plan will cover it. They'll cover it 80%, 100%, whatever it might be. It's always best for them as the member to call.
Absolutely.
And we also call on our end to make sure that it can get authorized. So that's usually where I'll recommend they kind of go from there. But we also do our part to make sure that the services will be covered under their particular plan.
And do they typically need a prior diagnosis? Do they typically need like a psychiatrist has previously diagnosed them, or maybe even their PCP has diagnosed them with like an ADHD or something like that?
Not necessarily, depending on your insurance plan, though, and carrier. A lot of times you'll need like a referral from a provider. So whether it's, pediatrician or therapist or whoever, for insurance to be able to cover it. And that's usually pretty easy. Especially for kids, most people are agreeable.
Especially in peds, everybody wants their kids to be taken care of, just like how you say that your relationship with the kids are.
Right.
Everyone's very focused. People don't get into peds for the money typically.
It's a different ballgame. Yeah.
It is. That's the unfortunate piece of a lot of passion specialties, is that it doesn't pay well, but it is so important. So you would be probably considered a very short wait time for folks that were interested in this kind of testing.
Yeah, I would say so, especially since we're only with one insurance carrier right now. And because it seems to be working, I don't want to take on more and make it even longer of a wait list.
Right.
So we're at that point right now. But if you're going to somebody who is credentialed with all of the insurance companies, the wait list is certainly going to be longer. And particularly if you are lifespan based. So if you can see kids, young adults, and older adults, your wait list is going to be longer for sure.
Oh man, it's tough. Do you have any idea of where the future of this is going? Like in the sense of, are there, like, so we all know that we have major medical shortages in mental health. Mental health, I think, is number 2. Primary care is number 1 right now.
Yep.
So, and we know that people are trying to churn out nurse practitioners like no one's business
Right.
to try to fill some of these gaps. There's a lot of shortages on the physician side of things. Thankfully, nurse practitioners are getting a lot more, and they've been largely emancipated in the state, but insurance companies don't necessarily agree with that. So it's hard for them to still, they're not completely free as a lot of people think that they are. So as in neuropsych, which is obviously a much, I can't imagine how many folks are graduating with their doctorate to treat also clinically, because there are a lot of people who get into psych and they don't get into it for clinical reasons either.
Mhm.
So is there, because we're expecting there to be a lot more nurse practitioners on the medical side, is there an expectation that this is opening up, that there's going to be a lot of people getting into this in the future, or do you see that, or do you even know?
I don't have the definite answer to that,
Mhm.
but I would say that the hope is that people continue
No
to get
question.
interested in this field because the demand is going to keep growing.
Yeah.
So
Oh,
we just
man.
don't have enough providers now. Like even if you go on LinkedIn, you're going to notice there's more job openings across the country for neuropsychologists than there are neuropsychologists. So the demand certainly is growing, and the hope is that we can meet the supply, right? That needs to kind of increase as well. But it's a lot of schooling. So
yeah, because so to perform this function, you are required to have a doctorate at minimum, right?
yes, you have to have a doctorate.
Okay.
And for neuropsychology in particular, your postdoc fellowship has to be 2 years rather than 1 year. So
Okay.
most other doctorates for anything like a irregular clinical psych, forensic psych, those things are only 1 year. Neuropsych is 2 years. So it does tack on some extra time, but it's necessary. We need that amount of training.
Right. Yeah, there's not going to be someone with it. Like, so are there ever situations where there are folks that are, because there are nefarious agents in every act of life, certainly in medicine as well. Are there folks that are trying to subvert this specialty as well, where they don't have the degree that you have and they're trying to conduct services like this? Is that occurring at all?
I think more and more people are trying to at least get some type of education on whether they can identify themselves, like therapists. A lot of social workers will kind of come in and say, like, is there a way I can get into doing autism or ADHD evaluations? Those are definitely more like targeted types of assessments they would do with like screeners asking interview questions. I think everybody's trying to just become a bit more knowledgeable.
Sure.
So I don't know that people are trying to be malicious in the sense of like, I want to do neuropsych without the training.
Right.
I'm sure there are some out there, but that's generally not what it looks like.
I know. I mean, the unfortunate piece is there. I mean, I couldn't find, I did a little looking around because I like to do that for really all of the folks that I interview with on the show. But, and you often find situations like that because it's just human nature. You have criminals in every walk of life. I mean, I learned early in healthcare that just because you wear a white coat does not mean you're a good person. Like there's a lot of terrible people in every industry. It doesn't matter what it is. So, oh man, I'm getting a lot of thoughts going through my head that are not appropriate at all right now. But I guess, because I imagine anyone that's going to be in doing what you're doing, they're going to be required to have these kind of credentials. So at least anybody watching will know that they have to at least be a Psy.D. Can psychiatrists do this?
Psychiatrists usually focus more on medication management. Some will do therapy. They won't do neuropsych testing, but they can sometimes give like quicker assessments, like screeners, to say, okay, this is justified. Let's send you.
And
for
they typically
a more
would kick it to you.
Yeah.
Okay. Great. Yeah, it's really interesting. It's such a great emerging field. And I imagine too, like what's the education process like going on? I mean, you must have continuing education because, like we talked about this, I mean, just the definitions of, having 3 levels of autism now, which wasn't historically the case. Understanding the groupings of some of these different mental illnesses and the overlap of them. Like I think a generation from now, you're going to have dozens of more diagnoses that fall underneath like the autism, like more specialized versions and better understandings. So there must be a heavy continuing education process for folks like you.
Yeah, we have to have a minimum for being able to renew our license, obviously. But the idea is to be up to date on research, right? And the research is constantly evolving.
Right.
The DSM, for example, they actually changed the DSM from, I don't know if you noticed, because if you ever seen it, have you seen a DSM before?
I'm not sure.
So they changed it from like the
What does that
Roman
stand for?
numerals. It's a diagnostic and statistical manual. It's what we use essentially for
For how you evaluate.
Yep, for any psychiatric and
Okay. Yes.
diagnoses.
Okay.
And it has all the diagnostic criteria.
Yeah.
Of course, things are constantly changing.
Mm.
We evolve the diagnostic criteria. We develop, a better understanding of things like autism and levels, and that things happen on a spectrum. So our training constantly has to evolve with that. So what does the research now say about, X, Y, and Z disorders? And what does that mean as far as testing, as far as therapies, what's going to be the best treatment?
Right.
So the idea is, even though I'm clinically based, right, I'm more a practitioner in the sense that I see patients consistently. You still have to keep up with the research, and you still have to keep up with everything that evolves within the DSM to be able to accurately know what your patient's dealing with and giving them the proper diagnosis.
And how often do you have to renew your licenses? Every 2 years?
Every 2 years.
Yeah.
Yep.
Good.
Yeah.
Sounds really good. Okay. I mean, I think we're in a good spot here. I mean, this is going so much quicker because I thought I was going to be with you forever on this one because I have a million things, but I feel like we're like ratcheting back and forth really quickly here. So, I mean, that's really a lot of what I wanted to talk to you about. I guess no, I think we actually have talked about that too. I was going to get into complex cases, but I think that we've really kind of run the gambit on, I mean, there's a lot more. I mean, I've learned a lot through this process too. I mean, just for prepping for this interview, because I didn't realize how useful it was for adults, for the elderly. And it just seems like there's so many more uses for this. So, I don't know if there's anything else that you want to leave us off on. I think we're pretty much at the end here.
Yeah, I think I would just like to encourage people, if there are concerns and people are curious, speak to a provider about it, whether or not it's a good option for you. I think a lot of people are just curious about how their brain works.
Yeah.
Like I'll have a lot of people come in and say, I just want to understand my brain, right? And know a little bit more about like me and how I operate.
Right.
Most people generally are pretty happy with the results, in the sense of, oh, I didn't realize I had this strength.
Yeah.
Right. And that's one of the things we like to point out. We like to point out strengths, not just what we're trying to target as far as weaknesses. So being able to balance that out for people and say, like, look, you're actually a really good visual learner. Like, let's optimize on that. So use visual aids when you need to, make sure that when you can get instructions that you can read rather than somebody saying verbally, like these recommendations that are a bit more, not necessarily subtle, but things that you might not think about because you don't kind of control how information comes into you.
Sure.
Right. You just take the information as you get it and you're like, oh, I just don't remember what they said.
Right.
Right. So knowing that about you kind of helps you be able to make certain day-to-day strategies that you can implement to make things a little bit easier for you.
Yeah. Cause I feel like, and I'm going to make this personal for a second for myself, but like and I have no business to self-diagnose myself with anything. I'm not qualified to say, obviously, not even close. I've had zero education. Everybody will say I have ADHD or whatever. And I mean, I'm a big proponent that I think like we all have all of these diagnoses. I think we all have anxiety. We all have OCD. We all have even autism and all but the problem is when it becomes a disorder. Like, when does it come to the point where it's preventing you from getting out of bed in the morning? So you can't go to work or school or whatever. When is social anxiety so bad that you can't even go into a mall or you can't go into a store? Like, if I have 1,000 people around me, I'm going to freak out. But I'm super extroverted. I love people. I get my energy from people, but even I have my limitations. And so I think everybody probably has that, but typically people aren't, losing moments of their life that are important because of that. So that's when I think it becomes a disorder or not. So I look at, I'm very forgetful for things. So I've compensated. I've come up with my own methods. So it's like, I need to bring this bag home. Like, so my brother thought I was like the biggest idiot the other day because I bring in this food. I'm doing this like 60-day cut right now. Today's actually my last day. And so, which is great. Over 20 pounds lost, lifting more than I ever have in my life. I'm loving this. I'm having a great time. Anyway, but I take my all the food that I made into work, and there's some food that I have even on the way home, because it's like, for me to get home, it's like a 2-hour process. I pick my kids up from school, and there's like a half hour in between each one of them getting released, and I have about a 45-minute drive home. So I have food I have to take from work into my truck on the way home.
Right.
So now what I do is when I get into work, I put my bag of food into the fridge and I put my keys in there because I can't leave work without my keys.
Right.
So I can't forget this bag. So I try to, come up with systems to outsmart my stupid self and figure out ways to kind of like get things done in life. And like, that's just one example of how there's many things like that in my private life. Like I know where my strengths are. I know where my many weaknesses are. And I try to surround myself with folks like in the work world that cover my blind spots. People who are like really OCD where I'm really not. That people who are super attention to detail where I am great in chaos. I'm great. Like when the sky is falling, I'm cool as a cucumber.
You're the guy to go to.
I honestly, I live even in my private life, I live a very chaotic private life and I love it. I don't want peace and quiet. My fiance sits on her porch like she's 80 years old every morning, sipping her coffee, listening to the birds. That would drive me insane.
But that works for her.
It works for her. So like we all have our own things. Like, I mean, I imagine, it's weird. So I personally because I'm sure there might be people out there too that are like, I would never want to get that done because I look at that and I'm afraid of what someone like you would find, like what's in there.
So one of the common things that comes up, I'm actually glad that you brought this up, is IQ testing. So a lot of people there are some people that are really interested in getting IQ testing. Other people don't want it because they're afraid that their test scores are going to come back and say that, they're a little bit lower than they should be.
Yeah.
Most of the time, that's not necessarily the case with a lot of people that come in and have that concern.
Yeah.
And I just try to tell them, like, this is not a pass or fail type of thing. Everybody's going to have strengths and weaknesses. You look a little bit different than the person that's going to come in tomorrow.
Yeah.
And that's okay. Yeah. That's what makes us, right? And individuals.
Right.
So that's one of the things that people generally kind of have.
I didn't even think of it in that direction. That's another, that makes sense. It's kind of like,
they have to almost talk themselves through it of like, okay, well, they're going to be testing my IQ. I'm going to get a number. And it's that number in like the percentile that they get worried about. Like, okay, well, am I like higher than most people or am I lower?
Yeah. Oh, wow. That's interesting. Yeah. I don't know what it is that holds me back from this. It's not that. I think it's just, I don't know. I guess part of me feels like I've got my shit figured out. Like, I feel like I know I feel like I run my life in a way that I enjoy.
Yep.
I don't feel super constrained. I don't feel like a failure. I mean, I have my setbacks like anybody else does. I have failures, but I don't, I think have, I'm going to say major disorder, but I'm sure then the comments are going to flood in from anyone that knows me that's watching this, telling me like, oh, really? How about this, Tim? How about that? But, I don't know. I guess it's hard for me to want to get over that heat, but I think it's something that's probably like, so let's say for instance, I do come to someone like you. It wouldn't be you because we know each other, but like someone like you that is then going to find out like, okay, well, these are your diagnoses. How does that now change things? Like, I probably know that I have these things. So what am I going to get as an adult when you give me that conversation? Like, I'm confirming you have this, that, and the other. And then is there a conversation of lifestyle there? Like, this is what you should be considering, Tim. The reason why this is important is like, do you provide like a narrative that helps understand better ways rather than me just figuring out organically through life?
Right. Yeah. So that's another great question. So you can come in and say, I have an idea. I think of what's going on. Testing may confirm or deny that. Right. And the diagnosis is just that. It's just a diagnosis. It just gives us a label to say kind of this, this is what we're dealing with. But that doesn't tell us anything about you and what your individual symptoms are. Because say you came in and you got diagnosed with ADHD, that's still going to look different than somebody else who comes in and gets diagnosed with ADHD, right? Not everybody falls within the same exact like boxes being checked.
Okay.
So the idea is to be able to tell you, well, here's what we're actually seeing in testing that maybe isn't something that you would think of day to day.
I think I see where you're going. Right? So like what you're saying is kind of like how I was saying earlier, I think there's going to be so many more subcategories as time goes on where like research gets further. My version of ADHD may be hyper-focused in certain areas and not really a big concern in other areas. So you can't give a blanket statement and saying, you have this, like if I have the flu, you know what to do to treat it.
Right.
But if I have ADHD, there could be, what you're saying is multiple, and not even just for the parts that are hyper focused in me, but also for how I live my life. What am I doing with my life?
Right.
Am I traveling a lot? Am I walking? Am I outdoors a lot? Like all these things are probably factors, right? They're all factors.
Yeah, absolutely. And that's the idea of the testing, is for you to come in and for us to, again, get that narrative of you as an individual. Yes, the diagnoses are important, but the diagnosis essentially is really just a label, right? We need to take a look at the individual symptoms, and that's what the testing helps us pull for. What's really going on with you, and how do we target what's specifically going on with you?
Right.
And go from there, right? The idea is to give you resources.
It's like awesome and terrifying. It's like, you know what I mean? Because it's interesting to think that you need to have a robust document that tells you about yourself. It's amazing that we can get our hands on something like that through someone like you. And it's also like, woof, like you, like I will have a nice glass of scotch while I read through my report. But like, you know, but I think it's probably something that can help a lot of people out. That's very helpful. That was a fun exercise. Okay. All right, cool. Well, anyway, I'm scrolling all your stuff up there because basically if anybody did want to see if they could be a potential client of yours, they can just go to your website is the best way, I imagine. That's what I put up there.
Yep, they can go to my website. Certainly feel free to email or call us, but the website should give a lot of information for what they need. And you can actually book your initial intake appointment through our website.
Ooh, right on it. They don't even have to call in.
Yep.
Okay, that's you know, because one of the frustrating things too is like I've gone to the PCP before about, you know, ADHD type of stuff. And they'll be like, okay, well, you know, we can prescribe you this for now. And then I'm like, it just didn't really work well. They're like, well, you just have to book a visit with this person and then just see how this does and then call this person. And it's like, and because of that, I'm not like, I don't put that in as a high priority. Like I'm running my business. I got dogs, I got kids, I got all these things that I'm dealing with that are high priority items. And maybe also part of whatever it is that my diagnosis will turn out to be, I'm not doing the fall. And I've talked to other people too, who are like, I swear, like if I had, you know, Adderall or whatever it is, all the different medications, you know, but I just can't get my butt motivated to make these phone calls, fill out these forms, go in for the follow-up and stuff like that because of what they suffer from. And that's also, I think, difficult. So I think anything you can do, like on the clinical side, to make things easier for folks like that too, like just having something where they don't have to call, they can just book it online. I mean, every little part makes it easier. So.
Yeah, especially when you're working or in school all day, you need to have some way to be able to do these things outside of the typical like workday hours. And a lot of places they close at 5 o'clock. So if you're working till 5, you don't have a chance to call. Makes it easier. So when you get home, you can just go online, and then from the intake, we determine whether or not testing would be appropriate. And if it is, we book your appointment. Beautiful.
Okay. I mean, it doesn't get more simple than that. I hope everybody learned a lot from this. So we're going to close it out. Our next guest is going to be Kevin Mulcahy, who is just an absolute master in Massachusetts insurances, and he has been victimized probably even more than me through the system. So he's just like one of those great speakers. He's got a good personality. It'll be we're going to have a nice fun one next time. It'll probably be in May. We'll see you guys at the next one. Thank you for joining us. And set the outro. See, I told you I was going to forget to do this. Outro. We're going to do the same outro thing. Bye-bye.
You managed. You got it done.
I think. Still, am I not out still?